Okay, I think we'll go ahead and get started. By my computer clock, it's 3:01 and we have a lot of wonderful content today, so I don't want to delay any longer. I think we're going to have some more folks joining us. So welcome everyone to our online chat, The Obstacle Course of Abortion Access in America. My name is Julie Gonen and I'm the Policy Director here at the National Center for Lesbian Rights. And with me today on the line also is our Communications Director, Christopher Vasquez, who some of you, or actually all of you, have gotten communications from about this event. And I do want to thank him for helping to make this event possible by setting it all up and publicizing it. And perhaps most importantly for me, showing me how to actually run a Zoom call. I've been on countless Zoom calls, but I've never actually had the controls of one. So we will see how that goes today. For now, all participants are muted, and actually throughout the webinar will be muted and off of video. So you'll just see the speakers on the screen, but you can submit questions throughout our discussion in the Q&A box at the bottom. And I'll be watching that throughout, and I will integrate your questions into those that I've already kind of queued up for our panelists. So I am very honored today to be leading a conversation with Carole Joffe and David Cohen, who've published an important new book illustrating the difficulty that people face accessing abortion care in the US due to the slew of restrictions that have been imposed by state legislators. David is a professor of law at Drexel University in Philadelphia, and Carole is a professor of sociology in the Advancing New Standards in Reproductive Health, or ANSIRH program in the Department of Obstetrics, Gynecology and Reproductive Sciences at the University of California, San Francisco. So we're a bi-coastal panel today. I've known David and Carole for years. They're both luminaries in the abortion rights movement, and David and I serve together on the board of directors of the Abortion Care Network. So I am just so honored to be part of this event with them today. So what we're going to do today is have an intersectional discussion about abortion access through the lens of Carole and David's new book, Obstacle Course. And I have a prop here. I have my copy of the book, and I highly recommend it to everybody. If you haven't read it before today, I'm sure you're going to want to after you hear our conversation. So what I mean by an intersectional discussion is that we're going to lift up the ways that the movement for LGBTQ equality and the movements for reproductive health, rights, and justice intersect with each other, and how the attacks on abortion access are of deep and real concern to the LGBTQ community. So as many on this webinar would probably agree, the LGBTQ and abortion rights movements have a whole lot in common. Obviously, LGBTQ people need reproductive health care, so attacks on access affect us directly. From a legal perspective, the rights that we have fought for and won are rooted in the same part of the Constitution, the guarantee of personal liberty in the 14th Amendment. That means that if courts continue to undermine abortion rights, and heaven forbid Roe v. Wade is ultimately overturned, it could have serious implications for LGBTQ rights as well. Now, one cool way that the intersection between our movements is becoming quite real is that reproductive health clinics are increasingly providing LGBTQ healthcare, and we're going to talk a little bit more about that later today. And finally, we have the dubious honor of being joined together in attacks from the Trump administration. The US Department of Health and Human Services under Trump has issued a sweeping federal regulation, for example, that would allow virtually any healthcare provider to deny care to someone based on that provider's religious beliefs. And of course, the things that are most commonly denied for those reasons are reproductive health services and services for LGBTQ people. The same HHS is also about to release another federal rule that would erase non-discrimination protections that were put in place under President Obama that prohibit discrimination in healthcare based on sex. The Obama administration said discrimination on the basis of sex includes, among other things, whether you've had an abortion, and also sex stereotyping and gender identity, which is how sexual orientation and gender identity are protected. Trump is trying to erase all of this. So to the extent that there may have been any question as to why an LGBTQ organization like NCLR would be hosting a discussion around abortion access, it should be pretty clear now. NCLR's tagline is Feminist Founded, Advocates for All, and we have long had reproductive rights in our mission. We have actually had to ramp up our work on supporting reproductive rights in the last few years out of necessity. We've been doing supportive legal work, for example, filing amicus briefs in some key litigation on behalf of the LGBTQ community. For example, in Whole Woman's Health versus Hellerstedt a few years ago, we filed a brief, and we have also filed one on behalf of LGBTQ people in June Medical Services versus Russo, which is a Supreme Court case pending right now. We've also filed briefs in lower courts around the Title X domestic gag rule. This work has unfortunately been necessary because attacks on abortion continue unabated. So, having said that, I'm still delighted to be hosting this discussion today of this important book that really illustrates the cumulative harm of the slew of restrictions imposed on abortion access in recent years. So let's get right to the conversation with our authors. So David and Carole, maybe you can start by giving us a quick overview of the book, why you decided to write it, what you were trying to illustrate with it, how you did the research, etc.
Well, thanks so much, Julie, for having us here, and to NCLR for hosting this, I think, really important intersectional discussion. You know, the book, you mentioned Whole Woman's Health, which was a 2016 Supreme Court decision, the most recent abortion decision from the Supreme Court, that struck down a Texas law. And what the court said in that decision was that what matters is the real world effects of a law, the burdens that it's going to place on people accessing care, and the benefits that it might provide. So after that decision, you know, it seemed like it would be important to lay out sort of how abortion access actually works in this country, not necessarily just the laws, what they are, but on the ground, how those laws impact people accessing abortion, and what the research is about those laws. So it seemed like the right time to try and think about sort of, and this is how we've organized the book, from the moment someone finds out they're pregnant to the point where they get a procedure, every step along the way, and the book is organized, each chapter is a different step, what the burdens are out there to make it difficult for people to access, and what that means in the real world of abortion provision. So that's what we wanted to do. And that's how the book's organized, to really capture this question. So we've got a legal right, because for now, there still is a right to an abortion. But what does it mean to actually try to access that right on the ground?
Yeah, and if I can add to that, and let me first also thank you, Julie, and thank Christopher for all the work putting this together. It's really a pleasure to be here. To add to what David said, we made the decision to interview abortion providers and allies and volunteers, and we'll explain more of these different categories as we go along. But we made a decision to not just focus on the red states, the quote worst states. We made a decision to really do all 50 countries. Sorry, California does feel like a separate country sometimes, but anyway, all 50 states and DC and Puerto Rico, because we wanted to show not only the diversity, but we wanted to show that some states are actually doing it right and really do offer a vision for how other states could operate.
Thank you. That's a great overview, and I'm sort of struck by, having just read the book, all of the obstacles that people who are seeking abortion care have to go through in normal times, and then of course now during the pandemic, we've seen some states move to actually make it even harder, if that, to the extent that's even possible, by forcing clinics to shut down, basically taking advantage or exploiting the pandemic. If I can do this, if I can walk and chew gum, metaphorically, I'm going to post a link to a piece that I did in The Advocate recently that sort of talks about that, and sort of the mercenary nature of undermining access to reproductive health care even further during a public health crisis. So one question that occurred to me while I was reading the book is whether you worry at all that documenting how effective these restrictions are will only encourage anti-choice politicians to enact more of them.
I mean, that's a really great question. And as an abortion scholar who's been doing this work many years, I've of course thought a lot about it. And then I came to this might sound self-serving, but I personally have come to the conclusion that whether we document the effectiveness or not, they're gonna do it. For various reasons we can get into later, state legislatures, especially since the 2010 election, that brought a lot of legislatures under total Republican control, have been doing one restriction after another. That is their strategy for getting elected. If they don't do that, they fear they will be primaried by even more conservative people. So I have come to the conclusion that whether we document this or not, they are going to do whatever they can do.
And I think it's a really important question in this regard too. It's just that, like Carole said, our book is based on interviews with abortion providers and people in the field. And we interviewed over 70 different people who work in all the different states. And we talked to every single person about this in the introduction. When we got their consent to do these interviews, we said there's a risk that by detailing what makes access more difficult, that the antis can read this and see what's worse. And they all thought, like what Carole just said, that it's important to get this information out there, because the only way that you can really convey to people the difficulty of access is by showing what makes access harder. Otherwise, people might be left with the belief that we've got this right to abortion from Roe v. Wade, and everything's great. So the providers want this information out there so that hopefully we can develop a saner policy somewhere down the line.
That makes a lot of sense. And I think also when fights around abortion access happen, it tends to be about one particular restriction, like in Whole Women's Health, one or two maybe, an admitting privileges requirement, or a requirement that abortion clinics have to meet all the requirements of many hospitals. And the focus tends to be on that one thing. But I think one of the geniuses of your book is that you string them all together and show how it's never just one of those things that's standing in the way of a person seeking abortion, that admitting privilege requirement is also there next to a bias counseling requirement and delays and other things. So I think the way you kind of walk through the different access barriers is really powerful and shows that these things are not, in fact, working in isolation.
Yeah, and I think that's it's important because, every state, or almost every state that has one restriction has multiple restrictions. And, so people who are dealing with poverty and can't get Medicaid to pay for an abortion are also dealing with the fact that they have to wait 48 hours between visiting the clinic and getting an abortion, and that they can only get abortions up to 20 weeks. So all of those things compound. And, I think that's an important aspect of what we're trying to show in the book. And there's some interesting litigation that's happening around the country from places like the Lawyering Project and the Center for Reproductive Rights, where they're trying to show that these restrictions, like you said, have compound effects. It's not just that one of them makes it unconstitutional, although I think everyone would agree by themselves they're unconstitutional, but that when you look at them all together, it's especially unconstitutional, if there's such a term, because it burdens people in just a much more significant way. And so we do want to show that in the book, how these things work in tandem.
And if I can just add to that, for those of you who are not steeped in abortion 24/7, like some of us, I think it's really important to know, in terms of everything that we discuss, for the next hour, that the abortion patient caseload over the years has become disproportionately poor and disproportionately women of color. 50% of abortion patients live below the federal poverty line, which is really minimal. Another 25% can be classified as working poor. So we have 75% of abortion patients who are poor, many of whom don't have cars, some portion of whom live in shelters, or if they have cars, live in their cars. So when we talk in the next hour about the various restrictions people face, remember that these are people who have very, very little resources to begin with.
I think that's another, I'm going to sound like your agent, but I promise I'm not being paid to do this, but
Feel free.
One of the strengths of your book, you're scholars and lawyers, and we often operate in the worlds of, data and studies and legal jargon. And I think what your book does is really kind of take it down to the level of a person who is actually trying to get the care that she needs. And I almost just said who's trying to vindicate her rights, but that's actually not the way we think about it, right? I think about it that way as somebody who works in sort of the legal world, but this is just people who are trying to live their lives, get the care they need, and all the struggles that they face. And you really kind of, you lay it out from the perspective of that person. So that's a real strength of the book, and it makes it very readable too. Even though it also is infuriating as you read it. So one of the phrases that you use in the book is abortion exceptionalism. Can you say what that is?
It's a phrase that's been used by some legal scholars. It's a phrase that's been used by some sociologists like me. But what it really points to is that in almost every aspect of the regulation of abortion, we see abortion treated differently. So for example, when in Texas, the case that David mentioned, Whole Women's Health, when clinics were told they had to become ambulatory surgery centers, issues like the width of hallways and the airflow and this and that, upgrades that cost, as the Supreme Court acknowledged at the time, could cost more than $1 million. Turns out that similar procedures that had many more deaths per year. I mean, abortion is extraordinarily safe, 14 times safer than childbirth in terms of, women's likelihood to die during, which is not an argument against childbirth, don't get me wrong. It's just an argument how safe abortion is. So things, clinics that did colonoscopies, for example, much higher injury and occasional death rate, not regulated in the same way. One of the things we talk about in our book is how important telemedicine has become to the delivery of abortion. And this is particularly true now during this pandemic. 18 states banned telemedicine for abortion when over-the-counter medications like Tylenol, and this is documented, I will shortly put in the website of my organization, ANSIRH, and you can find it there. Tylenol has more deaths per year than abortion. Tylenol, you don't even need telemedicine. You go to a drugstore. So, I mean, that's what we mean by this. What we mean is that abortion is treated differently than other fields of healthcare.
And actually, to Julie, your point earlier about the coronavirus pandemic being used as an excuse to make it more difficult. Just this morning, there was news about the governor of Georgia, who, Georgia is one of these states that's reopening earlier than medical experts recommend. And as part of the reopening, the governor has said that medical care professionals will not be subject to any liability, legal liability, as the result of reopening. He's suspending somehow medical malpractice laws for medical care providers, except for abortion providers. So there's a specific exception in what the governor has done for abortion providers. So all other medical care professionals can reopen and not have to worry about liability because of the pandemic, except for abortion providers who are under a totally different set of rules.
And it seems like most of the time they don't even have to explain why that is.
No, I mean, it's obvious, right? He hates abortion providers and he wants to get rid of abortion in the state of Georgia. And that's somehow legally okay.
Got it. Well, I think that you've vividly illustrated a great or a terrible example of abortion exceptionalism.
Right.
So one of the things that struck me, and many things did in reading the book, was the deprivation of dignity that's done to women and anyone seeking abortion care, and particularly restrictions, waiting periods that say to somebody who presents at a clinic for an abortion, oh, you should really go home and think more about this decision, as though she hasn't already. Also, the biased counseling, the scripts that providers are forced to read to their patients that often contain lies. So it just, together, again, cumulatively, it just seems like a real assault on the dignity of people seeking this care. And dignity, of course, is a very important concept in LGBTQ rights. As you know, all of the major LGBTQ rights decisions that came out of the US Supreme Court were written by Justice Kennedy, who's now retired. And he used the term equal dignity when writing his opinions, expanding LGBTQ equality, particularly the most recent one, Obergefell v. Hodges, which granted marriage equality nationwide. He talked about the equal dignity of LGBTQ people. So I'm wondering, and I think about this a lot, you know, how can we import that notion of dignity over into the fight for abortion rights? Because it really just seems like, you know, that's a real theme that comes through in your book.
I mean, I think the examples you gave and a bunch of other parts of the book go to that point, and it gets to second guessing people's own assessments of their own lives. And so if you are not letting people make important decisions about their own lives, such as whether and when to have children, such as who they love and who they have intimate relationships with, then you are not granting them dignity. I mean, I think that's what Justice Kennedy's getting at in all of the LGBT cases that he wrote. And he wrote he's been a big part of Planned Parenthood versus Casey, which is the Supreme Court decision in 1992 that upheld Roe. It's important to the recognition that we as human beings get to make the basic decisions about our personal lives. And, you know, you raised an excellent example, the waiting periods that we talk about in the book that a number of states have, where they require people to wait anywhere from 24 to 72 hours from first contacting a clinic to getting an abortion, to requirements that prohibit medical care professionals from referring to abortion providers or even telling people about abortion providers, to you know, religious exemption so that hospitals don't have to provide abortion care or related care. I mean, these are the same kinds of things we see that legislators are doing around LGBT care, whether it's states that are banning hormone treatment of minors, and we're seeing a bunch of those laws, or even states that are allowing conversion therapy against people's own wishes. So, you know, it really goes to this idea that we get to control the core of who we are. And I think that's where we see this immense overlap around the legal rights around abortion and LGBT rights, as well as just the basic idea of what it means to be a free human being.
Yeah, and if I can add to that, first of all, these waiting periods, in some cases it's 24 hours, in some cases it's 48, in a handful of states it's 72 hours. So imagine somebody driving, imagine a clinic, a state with only one clinic. So someone's driving many, many hours to get there, maybe from another state. And you're losing, if you have a job, you're losing days of wages, you're paying for childcare. 60% of abortion patients are parents. So these waiting periods can be extremely onerous. You know, we were told, providers told us again and again of patients sleeping in their cars in the parking lot because they couldn't afford a hotel or motel to stay in. But the alleged rationale for these waiting periods is so women can really think about it. Well, it turns out women really have thought about it. And we quote, in our book, we quote research done by some of my ANSIRH colleagues who've actually studied something that social psychologists call, quote, decisional certainty. In other words, my colleagues studied abortion patients compared to patients getting other procedures like mastectomies, like various reconstructive surgeries. I don't remember exactly the other ones, but basically what they found was a very, very high degree of, quote, decisional certainty. I mean, which is social science speak for simply saying that when people came to an abortion clinic, they felt it was actually the right decision for them. And the things beyond the waiting periods, one thing that a number of states require is making women listen, to their ultrasound. Women, it's changing now with COVID, and maybe we'll get to that. But until now, getting an ultrasound was pretty much a standard operating procedure in most abortion facilities. But the kicker here is that some states require not simply do you get an ultrasound, but the ultrasonographer or the doctor has to walk you through, this is your, quote, baby's lungs, this is the heart, this is this and that. In other words, just an incredibly upsetting, irrelevant procedure whose really only purpose is to make people upset. Again, my ANSIRH colleagues have studied ultrasound viewing, and they found out very, very few women changed their mind. Excuse me. Very few women change their mind. The tiny number who do are those who were ambivalent to begin with. Very few women change their mind, but it is nonetheless an upsetting, completely unnecessary procedure.
And it's unlikely that the policymakers who push these policies are unaware of that. I don't think that they're under an illusion that it's going to get a lot of people to change their minds. So they know that they are just subjecting patients to an unnecessary, demeaning and upsetting procedure. And it also, it completely denies the reality of what we all know, because we know so many abortion providers, that they are very good at counseling patients and assessing whether they do have this decisional certainty. And if they don't, they have no interest in going forward with a procedure with somebody who's uncertain, and they know how to counsel through that. And that counseling, ideally, it should be individualized and not following some script that an uninformed legislator wrote. So it's
That's right. No, Julie, you're absolutely right. Again and again, providers told us, we tell patients there's no do-over. If you're not sure, think it over more. In some cases, they send, very few, but in some cases, they tell patients go home. If you wait till you're really sure. One provider I remember told David and me she had nightmares about doing a procedure on someone who didn't really want it.
Right. So maybe let's talk a little bit about stigma, which I don't know if it's technically the converse of dignity, but it seems like a bit of a mirror image in a way. And it's another thing that I think our movements also have in common. We in both movements, we have to fight against the stigma. There a long time there has been and still is stigma around homosexuality, about being transgender. There's a lot of stigma still around abortion. So that's a common thing that we've had to face in trying to push forward on equality and rights. And an interesting thing that's been happening that you touch on in the book is the importance of storytelling, which can really go a long way toward dispelling stigma. It's been pretty well documented that LGBTQ people coming out made a huge difference in advancing equality, because people who know someone who's gay or who's transgender are far more likely to be supportive of those people having rights. So storytelling has been hugely important in reducing stigma and allowing for advancing policies that have been helpful to the LGBTQ community. So I'd love for you to talk a little bit about the advent of abortion storytellers and the promise this might hold for changing hearts and minds and maybe policy around abortion access.
I'll say this, that many people in the pro-choice movement are always saying, how come it works so well for LGBT people, not us? But more seriously, clearly there's obviously homophobia still exists, but there's been a sea change, I think it's fair to say. I was just before this webinar, I was looking at the data on acceptance of same-sex marriage, and it's extraordinary high, and it's changed quite quickly. With abortion, it's a little different. People want Roe to remain, but more ambivalence about abortion. And to be honest, I don't think we know yet the effectiveness of storytelling. I think there's a commitment to it, and several promising organizations are doing it. A clinic in Cleveland preterm is working with Renee Bracy Sherman, a very well-known activist in our field who's training storytellers. I think it's called We Testify. We have a brief mention of them in our book. So people are trying. To be honest, we don't really know yet how effective it is. I think, very briefly, there's real differences between coming out as a gay person and coming out as somebody who's had an abortion. If you come out as gay, this is who you are. If you come out as someone who had an abortion, maybe one, maybe two, it's not necessarily who even you think you are. Some people really own that identity and say, if you want to like me, you have to like the fact I had an abortion. A lot of people who have abortions don't even tell anybody. And in fact, there's research on that. Somebody at NYU did a big study comparing women who've had an abortion as opposed to women who had a miscarriage. I mean, no surprise, the women who had miscarriages were much more likely to tell other people. Not everybody. I mean, not everybody who had a miscarriage tells, but I mean, there is no stigma in that. There's sadness in that. And when you tell people that, they comfort you. When you tell people you had an abortion, maybe they comfort you, maybe they affirm you, or maybe they stop liking you. I mean, we have talked to abortion providers who, in some cases, whose family don't know what they do. So it's not a simple business to, quote, come out as someone who's had an abortion, or even someone who does abortions in some cases. I'll just say one more thing. I think one of the real heroines in the destigmatization of abortion is Shonda Rhimes. Shonda Rhimes, for those of you who don't watch as much TV as me, is the showrunner of Grey's Anatomy, of Private Practice, of Scandal, a number of TV shows that have really pushed the envelope on trying to normalize abortion. Popular culture has gradually started to change around that. We are seeing better representations in the movies and in some TV about abortion, but it's happening gradually.
David, did you want to add anything to that, or?
No, Carole got that. I mean, I think that there's the pop culture aspect of this is important. I mean, we saw that certainly, everyone around LGBT acceptance, people point to Ellen and Will and Grace and in the 90s, right? And the importance of that. But, we're seeing more and more on TV now, more accurate portrayals of abortion, women who get abortion, who don't regret it, who, go in and have the procedure and, they may be sad about the position they are in their life, but they're not sad about the procedure because that's what's important to being the full person they want to be. And we're seeing that more on TV and in movies in a way that I don't think we saw, 10, 20 years ago. And so there is hope. It's certainly complicated by some of the things Carole talked about, but there's hope that this is one of the things that will maybe change culture going forward. The combination of more people being willing to talk about it and pop culture incorporating abortion storylines into TV shows and movies in a way that, portrays the reality that 1 in 4 women have an abortion in their lifetime. As, Carole talked about Renee Bracy Sherman, she always says, everyone knows someone everyone loves someone who had an abortion. We just might not know it. So, the hope is that will make a difference down the line.
Just quickly, I put in the name of an ANSIRH colleague who's really documented. I mean, she has an incredible database for anybody interested. She's documented every TV show and movie in the universe that's ever mentioned abortion. But Mercedes, who's on this call, I urge people to go to the chat and look at her and look at her message. I mean, and that's a very promising development. What we're seeing now with TV shows is reaching out to clinics to say, tell us how to do this right. For you Friday Night Light fans, a number of years ago, which a TV show, of course, that takes place in a small town in Texas, they reached out to the whole women's health clinics in Texas for advice. So this is a very promising development.
I think the comment that Mercedes put in, this is from Mercedes Sanchez from Cedar River Clinics in Washington State. I think it only the panelists can see it, but she said essentially what you just said, Carol, happened with Friday Night Lights, that Grey's Anatomy reached out to them to get advice for one of their abortion episodes, and they had conversations with the producers and director. So that is really encouraging, so that they actually are getting information from where this happens, and it's not just based on old myths. And Carol, it's a fair point that you said that there's a big difference between being lesbian, gay, bisexual, or transgender and having had a certain kind of healthcare procedure. So I get that the analogy only goes so far, and maybe it's a bit of wishful thinking. But I think your book also shows this too, that because it walks you through the experience of people trying to get this care. And I think it just, if nothing else, should increase people's compassion for those who are seeking this care, because there are a lot of myths around it that I think do need to be dispelled. Let me move on to another theme that appears throughout the book, and we've already touched on it a little bit, and that's that a lot of these restrictions that legislators put on abortion, even though they look like health and safety regulations, they are not at all based in science or medicine, and it's actually ideology dictating medical practice, which is pretty scary. Policymakers basically ignore the experts and impose requirements on abortion that actually interfere with healthcare. Sometimes they literally say the best method is you may not use it because we don't like it. So this is abortion exceptionalism that you were talking about earlier. Abortion care is highly politicized, probably uniquely so in healthcare. However, as you just touched on, David, we're starting to see legislative interference with healthcare for transgender people, and particularly for youth. I was just checking, lawmakers in at least 8 states this year have introduced bills that would literally criminalize providing transition-related care to young people. They would impose criminal sanctions on providers, even if they're providing care that's consistent with guidelines from medical organizations. So I wonder if you have any thoughts on lessons that we can apply from years and years of abortion care being politicized as we fight these efforts to do the same thing to healthcare for transgender people.
Yeah, I mean, I think there's multiple lessons. I mean, one is that when you have medical expertise from organizations that are not seen as political, to lead with that expertise. So, the American College of Obstetricians and Gynecologists, the American Medical Association, they're clear about, these are not left-wing political organizations. And I don't degrade left-wing political organizations. I'm a member of many. But, these are neutral medical organizations that lead with medical science. And when they support, when they give medical guidelines to lead with those, when they say that abortion care should not be made to full of delays and lies from legislators, and providers should be, more widely accessible, and that medical abortion is safe and should be able to be given over the phone or even at a pharmacy. When these organizations say that and they have the science behind it to lead with their assessment of the science. And, in the example you gave with the bills for hormone therapy for kids, the American Academy of Pediatrics has been clear about that if this is something kids need, that it's okay to treat them. And I think it's important that they are speaking out and that they are part of the voice on this issue. Now, that doesn't mean that we should let the medical experts be the only voice. We need the voices of patients so that people can hear about their lives and hear the struggles and hear the reasons. And we need the voices of the providers to talk about how they want to care for their patients. So I think it's all of those things together. So I think that's the good thing we can learn. The bad thing we can learn, I think, is that the forces on the other side, who are, the Venn diagram is, pretty tight, who the forces on the other side are here, that, they really don't care about the things that I just mentioned. They are bigots. and they want to control people's lives. And they're not going to listen to the medical science. They're not going to listen to people's stories. So it's not them that we're talking to, really. It's their constituents. Because maybe their constituents can be convinced that this person that I put into office is not a good person. They don't like my sister-in-law or my neighbor who had an abortion or who is gay or who is trans. And that's not okay, because I do like that person. And that person is important to me. So, I think we're speaking to them, because the legislators, when they've gotten to that point, they are really set in their ways, and we need to get them out and get better people in.
Right, and I think another audience maybe down the line is also going to be, unfortunately, judges, because we constantly have to go to court to vindicate abortion rights, and we're having to do that now for LGBT rights too. And it doesn't always happen, but often judges will look to see where the evidence is when a restriction is challenged. And sometimes, the judges are not much better than the legislators, and they'll pick and choose what they want to listen to or minimize the impact of an AMA or the American Academy of Pediatrics. But sometimes they do the right thing, and they look and say, well, this really makes no sense. If American College of Obstetricians and Gynecologists says this is a bad thing or this is contrary to best practices, we should pay attention to that. So I think that's a great point, David.
Yeah, and that, getting back to what you started this conversation with, that was also one of the reasons why we wrote this book, is because the Supreme Court in 2016 said we do care about evidence. Right. And so, it was really about Texas, and it was about the particular provisions in Texas. But Carole and I wanted to put that all together, the evidence that's out there, because the evidence that's out there is very compelling. Abortion is safe. It is common. It is a pretty simple procedure for most abortions. It's important to people's lives, but it's not something people regret. And, people who are impacted by these restrictions, it's not that the abortion is difficult for them, it's that the restrictions are difficult for them. And the restrictions make their lives, more expensive, more complicated health issues. It's not the abortion that does that, it's the restrictions.
Maybe the book will have to just be a standard amicus brief in every abortion rights. Since you kind of brought it all together. I want to actually take one step back to our last discussion about stigma, because we got a question from one of the attendees who said, I would love to hear speakers' thoughts on the portrayal of and importance of seeing and hearing faithful providers and patients as a means to change the culture of stigma. So people of faith who are both abortion providers and those who have sought this kind of care.
And I would add to that the importance of the faith community as advocates for abortion. I mean, we tend to think of only religious only religious groups like the Catholic Church, like evangelical churches being against abortion, which they are very effectively, but there are very strong voices of support for abortion within the faith community. And this goes back to the pre-Roe days when we had something called the clergy consultation service. It was Protestant clergy, some rabbis who actually served as an abortion referral service. But yes, a lot of providers tell me that they do this because, not in spite of their religious orientation, but because of it. Willie Parker, a doctor in the South, an African-American OBGYN, was raised fundamentalist, still is a very devout Christian, and he has said publicly and in his memoir that he does this because, the Good Samaritan story really changed his mind. For many years, he didn't do it. He listened to a sermon on the Good Samaritan, and then he said to himself, I have the skills. How can I not help? So yes, I think providers, those who choose to provide have come, if they are religious, have come to terms with it. And as I said, do it on the basis of their faith. Many patients do, however, come to the clinic from a very religious background and have real issues. You know, am I going to go to hell? Is this really murder? Will Jesus still love me? I mean, these are very serious, heartfelt questions that the abortion providers we are in touch with take very seriously. Some clinics actually hire chaplains. This was pioneered by Dr. George Tiller in Kansas. Dr. Tiller, of course, is the abortion provider who was literally assassinated in his church by an extremist person. I will not swear on this webinar. Anyway, so yes, we have both providers and patients with deep religious convictions, and I think it's fair to say the abortion providing community does its utmost to try to address the concerns that patients have. And if a patient comes to the conclusion, and this happens occasionally, although very rarely, if a patient says, I could never feel that God would forgive me, then she is counseled to not get one. I mean, if that's really how if that's the most important thing for her, the clinic won't do it.
Yeah, I'm really glad that question was raised, because I think it's because of how vocal abortion opponents tend to be and how often they invoke religious reasons. It can seem as though all people of faith oppose abortion, and that people who are for abortion rights are not people of faith, and that is of course not true. I was on a webinar recently that was put on by the National Council of Jewish Women, which was very interesting because it also pointed out that there is a real diversity across faiths about abortion and the status of a fetus or embryo. And we tend to get this monolithic view that the religious view is to be against abortion, and that is absolutely not true. Right. So I'm glad we brought that into the conversation. Maybe we can pivot to something that's a little bit more fun, and I'm so glad to know that Mercedes from Cedar Rivers is on here, and that is the provision of LGBTQ healthcare in abortion clinics. It's kind of an exciting thing that's been happening for a while now. Clinics that are providing abortion care are also specifically marketing primary care in some instances to LGBTQ people, providing care like hormone therapy for transgender patients. In our Supreme Court amicus brief that we did at NCLR this year in the June medical case, one of the things we highlighted was that if you allow states to shut down abortion clinics for bogus reasons, it's actually not even just abortion care that's going to disappear, but some of these other services that members of our community have come to rely on will also go away, because abortion clinics in some ways are uniquely situated to think about stigmatized populations and providing care for them, as we were kind of just talking about. And in the book, you mentioned this in a couple of places, that some of the clinics that you interviewed or where you interviewed people were doing this. So I'd love for you to just talk a little bit about that. You know, why are the clinics doing this? Why did they start it? You know, what benefits do they see from doing this, which to some people might seem a little incongruous. You've got abortion care and you're providing hormone care for trans folks. Like, why is that happening in the same place? But in some ways it actually makes sense.
It does make sense for all the reasons you've suggested. I mean, I think, as you suggested, a commonality of interests. I mean, whether they use the word intersectional or not, I mean, there's a recognition that we are in many ways connected to each other. I think people who do the same thing all the time like to diversify. I remember when trans care first started in clinics, maybe 7, 8, 9 years ago. I remember how excited the providers I was in touch with, the frontline staff, I mean, in part because they felt it was, you know, politically a good thing to do, but also they were just learning a new thing. I mean, they were, abortion care is extremely interesting sociologically and legally. As a medical procedure, it's quite routine, which is, I mean, and safe. I mean, an aspiration abortion takes, which is the first trimester procedure, which about 90% of women in this country get, is over in 5 or 10 minutes. A medication abortion, which is very important these days because of COVID, it involves handing a patient pills. And I mean, I don't want to say, please don't hear me saying, especially with Mercedes and other clinic people on the line, don't hear me saying it's boring work and you're bored. I am not saying that. What I'm saying is that I think it's very compelling to do something new. And what is very poignant to me about the current COVID situation, and we haven't talked too much about it yet, I mean, but what's going on in the clinics now, who are desperate to stay open, who are desperate to figure out how to keep the patients safe, how to keep the staff safe. I mean, they are facing the same problems that all healthcare workers are facing, except, as David pointed out, they are not free from litigation. They are trying to be shut down by some red state governors. But nevertheless, clinics are open. But one thing that's happening, and I have just actually started research on how the clinics are responding. One thing that's happening is that because they can only deal with fewer patients, they have to space them farther apart. They have to make sure that one patient, you can no longer have the clinic, the waiting room like you used to. Now the clinic waiting room is the parking lot. People wait in their cars. But anyway, what's going on is that they've had to, in many cases, cut back. So clinics that used to do contraceptive care, regular gynecological care for both LGBTQ people as well as straight people, trans care, in a number of places, this has had to be cut back. And that's very sad. I mean, it's sad for the providers who are really committed to this work, and it's obviously sad for those patient populations.
And I'll just add, and I think that there was actually a comment in the chat room about this, which is that I think one of the reasons why you're seeing, I mean, so look, there are a bunch of clinics out there in this country who all they do is abortion. They are abortion clinics 100% because that's what their model of care is. And then you've got a lot of clinics that provide some reproductive health care, contraceptive care. And then you've got others like we're talking about that have expanded to provide other forms of care like trans health care or even birth centers and birth care. Mm-hmm. And I think that part of it is that these clinics are seeing that their mission is to fight gender roles in society, to fight traditional gender roles, and that what the enemy, the anti-abortion folks, like I said, the Venn diagram overlaps with the anti-LGBT forces because it's about controlling people's gender and controlling women's position in society and traditional notion of what a man is supposed to be and what a woman's supposed to be. And so when you're fighting that enemy on one front already, and, I'm not saying that people in medical care are necessarily fighting because they're just providing care, but when you're working in a field that's already part of, being vilified by the enemy in one area, to add another area that's part of the same big whole picture, feels like a natural fit. It feels like we are helping people, live their best lives, make private decisions about their best lives, but also, helping people fight the gender roles that are put upon us in terms of being pregnant when you don't want to be pregnant, or living in a certain identity that doesn't fit with the identity that you feel is your identity. So I think it's all part of the same picture, and a bunch of abortion providers around the country are seeing that and seeing that they're a natural fit for this kind of care. And they really like being able to see a new population that values the privacy that they can give, that's a natural part of their care, and the understanding and the counseling that is a normal part of abortion care can come with that and into the trans care. So I think it's a natural fit in so many ways.
Yeah, and let me just say the obvious that we somehow didn't say, that trans people get pregnant and don't necessarily want to get pregnant. Lesbians get pregnant. Sometimes they want to, sometimes they don't. So it's not just these other services, it's that these populations need the same kind of service that you can get in an abortion clinic.
Wonderful. Thank you so much, David. I was going to go to that question in the chat, and you just masterfully worked it into your answer to that. So that's great. I think that's exactly what I've also heard when I talk to some of the providers who do this. And I think it's just a really exciting development. I know we're getting close to the end of our time, but I just really want to get in one more question before we kind of wrap it up. You know, one of the, and you guys have been touching on this, one of the major obstacles for people obtaining abortion care is a lack of providers. You know, some states have literally one clinic left. And as Carol was just saying, clinically, abortion care is fairly straightforward. And ideally, you'd be able to get it, you know, in your primary care doctor's office or your OBGYN's office, or, you know, advanced practice nurses can do this too. But many providers don't get trained in it, and they don't want to do it because of the stigma, the discomfort of colleagues, and fear of harassment and violence, frankly. And it reminded me of something at NCLR. We have this campaign called Rural Pride, where we go into rural communities to talk to LGBTQ people who live there to find out what their unique challenges are living in a rural space. And I remember we were in North Carolina, and there was a primary care physician who sort of had just de facto become the go-to provider for trans folks in that area. And so a lot of other doctors would refer their trans patients to her. And on the one hand, she said, well, that's great. But on the other hand, she thought, well, it's not great, because you shouldn't just send them away to me. You can do this. It's not hard. It's not rocket science. I will help you become more culturally competent so that you can care for your patients and not send them to somebody else because you don't feel like you know how to do this. And so, again, I know the analogy is not perfect, but I wonder, you know, how can we get more clinicians comfortable with providing abortion care and fight some of that stigma, and maybe use existing providers, sort of appeal to their colleagues in that way and say, this isn't something that should be carved out and sent over there. You can do this. More clinicians should be doing this.
Yeah, I mean, that's a great question, and it's a very tricky one. I mean, it really goes back to right after Roe, when the freestanding clinics were first set up. And they have done a fantastic job with an incredible safety record, and hiring staff that are very abortion positive. And that is not something that can be taken, you know, for granted. So when medication abortion first became approved in this country in 2000, a lot of people had the fantasy, okay, now, exactly as you're saying, now every primary care doctor in the country, you know, should be able to just, I mean, primary care doctors know how to size a pregnancy, know how to hand somebody pills and counsel them. Why isn't everybody doing it? And it turned out that the take-up was actually very minimal. The people who started doing medication abortion were the clinics who just added it to their repertoire. And I actually did some research then. I actually talked to doctors trying to figure out, well, why aren't you doing this? And it was in part what you said, the stigma and the discomfort, but it was also the not having a clue what the restrictions were. Clinics have lawyers. Clinics have people whose full-time job it is to say, okay, we have to, you know, we have to wait 24 hours. It has to be the same doctor who, in some cases, who counseled her, who does the procedure. Primary care doctors didn't have a clue. Oh, I have to report each abortion I did. So, I mean, it is a combination of things that made it, I mean, doing abortion care is very cumbersome. And somehow the fantasy was that you could somehow do it secretly. And I remember when a medication abortion was first approved, I talked to colleagues who I'm sure you know, Julie, at the ACLU Reproductive Freedom Project. And what they said to me, I mean, this was 20 years ago, and I still remember it. They said, Carol, you can't do abortion secretly and legally. You know, if you're going to do it, you have to say you have to report to the state, you have to fulfill your state restrictions. So it has been a complicated thing. Hopefully it will get better. I mean, medication abortion is proving so valuable during this epidemic, excuse me, that a number of doctors are realizing this is really the only way to do abortion safely during a pandemic. I shouldn't say the only way, the best way. I don't want people to think, I mean, medication abortion now in the United States is being done till about 11 weeks. And some people need an abortion after that. So I don't want to say we're only doing first tries. That's not true. And I do want to point to the chat box where Lynn is telling us about the Midwest Access Project to learn more about training the next generation of providers. Yes, organizations like Medical Students for Choice, like the Midwest Access Project, are like the Fellowship in Family Planning that's headquartered at UCSF, but that's all over the place. I mean, there are a lot of people, Julie, working on this very problem.
Which is a good thing. So I hate that it's 4:01 because I would love to just keep talking to you, and I'm sure that the folks listening would love to keep doing so as well, but we did promise that it was an hour, so we probably should wrap up. And I guess I would just ask each of you to maybe say what you would like folks to take away from this, and maybe what they can do to help deal with some of the problems that you've outlined in your book.
Yeah, you go, David.
Yeah, I'll start. So there's two things. One, I want people to take away from this that it's not bad everywhere, that there are actually a lot of states doing this right, and we've seen some amazing improvements around abortion access in the past couple of years when we've seen progressive legislators taking over city and state legislative bodies and realizing that they can actually improve access. Just like the right has been restricting access, that blue states and blue cities can do things to improve access. And there are some great models around the country of improved access. And that gets to my second point in terms of what we can do. You know, it's trite, but it's true. Voting, you know, here in Pennsylvania where I am, I always like to tell people if you're not doing it twice a year, every year, you're doing it wrong, because you need to vote in the primaries and you need to vote in every local election. The president does a lot, but actually abortion policy is determined locally. So you need to be voting locally as well as nationally. So it's voting. You can donate to abortion access funds or practical support groups to help actually get people access. And then you can also escort, which escorts are volunteers who work, they don't work, but volunteers who go to clinics and they help patients actually get into clinics because they're protesters outside clinics in most places around the country. And so to have a patient escort literally walk with the patient into the building and say nice things to that, whether it's just, hey, do you see the wonderful flowers over there? You know, to take their mind off of the protesters who are yelling at them. It's a really concrete thing that people can do to help their local abortion clinic. So I think this is absolutely one of those areas where the old environmental slogan works. You think globally, but you act locally, because your local clinics, your local fund, your local politicians need your help to improve abortion access.
Yeah, I would echo everything David said, and I would especially say that during this pandemic we're having, when women are having to travel, and travel now is very tricky. What I would recommend people who feel moved to help in this area, call your local abortion fund, or call the National Network of Abortion Funds, or call the National Abortion Federation. Any of these groups. How can you help? If you've been absolutely quarantined, do you feel comfortable driving somebody if she's been quarantined? People are going to need all kinds of help, not now more than ever. And I want to absolutely emphasize, again, at the risk of sounding lame, how important it is to vote, and to vote down ballot as well as national. Republicans have been much, much better at voting locally and at the state level than Democrats, who tend really just to vote for, senators and presidents. But, we have stories in our book of a clinic that wanted to open in a certain area in a town, but the city council called, or the zoning committee of the city council called a meeting. The meeting lasted all of 4 minutes, and the only item on the agenda was to say, no, you can't locate there. If there had been a different person on the zoning committee, it would be a different story. So anyway, please vote. And thank you very, very much, Julie and Christopher, for having us.
There is nothing lame about reminding folks to vote. It's incredibly important. So we are in fact going to wrap up now. And I will note that this program was recorded, and Christopher is going to be sending everybody who participated information about how to get that recording. And I will, once again, I'm going to use my prop and recommend the book.
Thank you.
And thank you so much, David and Carole, for taking the time to discuss these important issues with us today. And thank everybody for attending. I'm sorry we couldn't see and hear you, but I think this kept the conversation sort of manageable. So thanks again to our panelists, and take good care, everyone. Bye-bye.
Thank you all.
Bye-bye. Thank you. Bye-bye.